First on the agenda today is Professor Donna Hall. Donna is currently chair of Bolton NHS Foundation Trust, which has a very special place in my heart. It's where I started my career in the NHS. And she's also chair of New Local, which is the think tank and local government network. And she's also an advisor for integrated care for NHS England. She spent most of her career working in local authority across the Northwest, including a CEO of Chorley Council here in Lancashire and South Cumbria, and a number of trusts across Greater Manchester, including Bolton, Salford, and, as Fred said, Wigan, where as CEO she led the introduction of the Wigan deal. And she's going to talk to us today, I believe, in terms of how people and communities can support the NHS and create health and wellbeing and bridging that. So Donna, very warm welcome.
Oh, thanks very much, Lenny. It's great to see you all, and lovely to hear that you started your career at Bolton. That's fantastic. So Bolton is my hometown. It's where my children were born. It's where my sister's a midwife there, and it means a lot to me to chair my local FT. But can I just turn your question on its head? You know, you said, how can communities support the NHS? I want to talk about how can the NHS support communities, if that's okay. That's definitely what we're trying to do in Bolton now, because I think, you know, people hold up the NHS as this kind of pariah, don't they? That it's, you know, and sometimes we forget that the real strength, as was just said in the intro, is in local communities. That's where health is made. I don't know if you've read Lord Nigel Crisp's book, but it's hospitals are for repairs and communities is where health is created. So it's fantastic that you're doing this. I think it's great that Lancashire and South Cumbria are kind of getting ahead of the curve on co-production. And I'm just going to be really honest about things that I've tried that have worked and some that haven't, because I'm not perfect. And I think that's where we need to kind of really start from as NHS and local authority leaders, is political and managerial, is to say we haven't got all the answers. And that's why events like this today are really, really important, that we listen really hard to local people and find out what we're doing well and what we're not doing so well, and change as a result. And sometimes step back and let communities do things that they're better at than we are. So I'll talk a little bit about Wigan, if that's all right, because it was a great whole system piece of work that they're still going on now, even though I've left. And I think what you tend to get sometimes in partnerships is you get a strategy that only lasts as long as the leader, you know, the leader who's in there. But the good thing about the deal is it was a strategy for place, a strategy for one of the largest Met areas in the north of England, and it sticks. So it's not just, it outlives the politicians and the leaders, managerial leaders who might move on. Because I was doing some work in Birmingham last year, and they've had, within 4 years, 7 different chief executives of the council, and within that time frame, they've had 7 different strategies. You know, 7 different ways of working, and that's just not good. It's not sustainable, and it doesn't build that trust up with local people. So the deal was all about a relational model where we said to communities, we haven't got all the answers. We want you to tell us what to do differently. It involved the political leadership. It involved across all parties. It involved all of the officers in the council, everyone who worked as a public servant in Wigan. It was the police, the NHS, primary care, the community and voluntary sector, housing, Department of Work and Pensions, you name it. Anybody who was living or working in Wigan was part of the deal. And the first thing about it was we haven't got any money. That was the starting point. Because we were number 3 on the list of most cut councils in the UK at that time. And we had to make a huge amount of financial savings, as most other councils have had to do. But we knew we had to reinvent our role. We weren't there just to chop little bits off services and to pass the burden of increasing council tax onto residents to help us get out of this situation. So we froze council tax. That was the first pledge, and we froze it for 8 years. And that meant about £500 for a Band D property per household per year extra. If we'd have just put council tax up to the maximum, then each household would have been £500 worse off. So that was our kind of first kind of signal that, look, we're going to try and find these savings internally, but by working with local community groups. And what we thought was, we're going to use asset-based, strengths-based working. I'm sure you're used to that terminology, but for us, that was what we've not got any money. We've got huge pressures of demand in our system for health and care and housing and support generally, particularly mental health support. And so we worked with, I don't know if you've come across her, she'd be a good speaker for one of your future events, Hilary Cottam. But she's written a fantastic book, which if you haven't read it, I really recommend everyone at the conference today to have a look at it. It's called Radical Help. And it's about how do we redesign public services to make them much more person-centred and responsive and relational. And people try doing it in a little bit of the organisation, but we thought, we know this is going to work, let's just do it across everything we do. So that it was quite different and quite bold. So in the end, we managed to save the money, almost 200 million. We managed to freeze council tax, and the most kind of significant outcome, I think, is the increase of 7 years of additional healthy life. So in the most low-income areas. So I think it's better to call it low-income rather than deprived communities, but areas with lower levels of income coming in. And 7 extra years was a huge amount of life where people, so at one point it was 50 years old for men. That's 50 years to get to the age of 50. And then after that, you're in poor health, poor and declining health. And that's where communities can help the NHS and the other way around. So we invested about 13 million into 500 amazing projects that they weren't created by us, they came from the community. We thought we knew what people wanted, but actually when we listened, we found that there were some fantastic things. Some of them weren't hugely expensive. So things like supporting a singing group, travelling around pubs and community centres in Wigan to support people with chronic obstructive pulmonary disease. And that was increasing people's lung capacity by 20 to 30%. Things like men's walking football for people to get them back into good health. We had something, it wasn't called a dementia support project. We didn't want to stigmatise it, but it was called a rugby memories group for people, because rugby is a big thing in Wigan. And it was to support people so they could come together rather than sitting in a drafty day centre with people they didn't know and had no common bond with. Let's support a rugby memories group. Let's get Wigan Warriors on board. Let's get the players to come in and meet people and chat with them and bring old programmes that trigger good memories for people and make it fun, make it enjoyable. Again, that cost hardly anything. And what we found was people really responded to it. Businesses really responded to it. Heinz, every tin of beans you've ever had in your life is made in Wigan. So Heinz beans really responded to it. We had a deal for business, we had a deal for schools, for children and families. Every department of the council was involved in it. Adult social care really drove it, actually. They were they were at the vanguard of it. Children's services, policy, even finance. So, I never thought I would see the day when a director of finance would say, here's £13 million to put into prevention. But that's the kind of forward-thinking attitude that you need as a partnership, is let's focus on prevention. That's how we can support the NHS to stay standing. And what's the alternative? People think, you can't do all this high-risk investment stuff without a fully fledged business case and a robust monitoring procedure. Well, I think the biggest risk we face as public services is not doing this stuff, to be honest, because we know that public services are going to fall over if we don't do something radically different. I've just seen a report today in The Guardian about workforce reform and how unless we transform the workforce to make it more flexible around the person as they get older, because people are living longer, which is great, then, we're not training enough geriatricians. We've got very fractured and silo services that don't support people, particularly in the last 1,000 days of life. We hear a lot about the first 1,000 days of life, but not a lot about the last 1,000 days of life, where I'm sure you will have family stories and stories that are personal to you. But my mum, who sadly died now, had 22 different bits of the NHS and social care came up her drive on the day she was discharged from Bolton Hospital. 22, none of them working together, all of them fragmented, none of them asking about her situation in terms of her family support and her networks and what she liked to do. It was all just very siloed, medicalised, separate bits. They're all very well-meaning people, but they weren't working together. And I think that's why ICSs have been set up, haven't they, to kind of combat that. But let's try to think about how we train the workforce to have different conversations with people. Focus on the assets and the strengths, not just what's the matter with you, but what matters to you. Concentrate on the good things about people's lives and help to try and create that good life, as Hilary Cottam talks about in Radical Help, through everything that we can muster. I think finally, integrated place-based teams are really important, particularly in places like Lancashire and South Cumbria, where you've got very complex geography, areas of quite relative affluence, cheek by jowl with really areas of low income and people really struggling. So focusing on populations of between 30 to 50,000 with really brilliant integrated neighbourhood teams working together across health, social care, the police, housing, and really trying to have case conferences about individuals and families to make sure that you're focusing on individuals in a different, more whole system way. We used risk stratification quite extensively in Wigan, so I'm sure you'll be using it in Lancashire and South Cumbria through the CCG's work. But basically, we could tell from a population of 323,000, we could pinpoint the almost 4,000 people who were at risk of an unplanned hospital admission. And then instead of just sitting there waiting for them to pitch up in A&E, we would go out there through the primary care network to offer support, whether it was a community project to help them be made aware of, depending on what they love to do, or whether it was things like, we didn't call it social prescribing because we found that quite paternalistic. It was implying that the GP had the power through the prescription pad, where it was basically, this is what's available. If you want to do it, then here's something called a community book, which maps out everything that's going on in your local area within a walking distance or a bus ride or a 5-minute car journey, so that it was enabling people, and also using digital tools to be able to get people to self-prescribe for what they wanted to do. So that's it from me. I hope that's okay. I hope that gives you a bit of a flavour. But again, similarly now, we're using a lot of that stuff in Bolton. We see ourselves as a community organisation, part of the community. Some kind of bigger FTs I've come across, it's almost as if they could be operating anywhere in any part of the country. They're like a hermetically sealed, medicalised model, where the people who work there don't know the community. They don't understand, the nature of the community. We've employed somebody called a community outreach midwife, who goes into local areas. So BL3 is the postcode where we have so many of our stillborn babies. So she went in to kind of work with the local community to try to find out why. We've set up a health hub in that local community, so the midwives work out of that health hub. So it's very much a community outward, turn the hospitals inside out, I think, is the answer, to make them accountable to local people. So I hope that's okay, and I've not gone over time.
Thank you very much, Donna. And again, in the real world, we've been a rapturous applause. I see we've got a digital applause for you then. And what a great introduction to the work that you've done and the work that you continue to do. So the question that's come up on the chat from Simon is wanting to know about low-income and deprived communities and the criteria used to decide which communities require more support. Now, I know that there'll be some complex formulas around that, but I also know from some of the stuff that you talk about on Twitter, and again, as you've just said, how can we reframe that and how can we really start to think radically different about how we resource communities and what have you. So it'd be great just to get a bit of info from you and your thoughts around how we can resource communities differently around income and costs, etc.
Oh, thanks, Lenny. I mean, I'm a great believer in a universal basic income, but obviously, that's not something that integrated care partnership can bring about in a local area. But I do think it's important that as people supporting people in areas of low income, that we have a really detailed understanding of where they are. And that's why I think risk stratification is good. So using the I don't like these words, index of multiple deprivation, but you can map it out. And very often those, what I call super output areas, I'm sure you know what they are, but they're seen as being, they've been like that in many areas for generations. So it's not just a sudden thing. And what we've tended to do in the past is money has been parachuted into those areas through pots of regeneration cash to try to help people, but it hasn't actually helped people because we've not shifted the relationship between public services and local citizens. It's been very paternalistic. Like I think it was Talib said at the beginning, you know, we're doing things to you. You don't have a say in it. This is what you will get. You'll get a day centre, you'll get a bed in a hospital, you'll get, you know, if you wait 6 months, you'll get a referral to a mental health support service, you know, and it's not good enough. You know, it's not what people want, and it's not early enough. Timeliness is key. So I think, and people don't want to be described as deprived. It's not their fault. It's low income. You know, and we've got to support people, you know, through an economic lens, I think, as well as a health and care lens. We've got to try and get people's income up because there's such a strong correlation between poverty and low income and poor health. You know, it's Marmot says it all the time, doesn't he? In all of his reports, Build Back Fairer. So I think we've just got to focus on those 6 Marmot recommendations as, you know, a real sense of purpose for the integrated care system.
Brilliant, thanks, Donna. I know in the chat Simon wanted to add something to that, but I think hopefully what Donna's said might have filled in, because we've just got a bit of time where I think I'm going to ask you 2 questions, which I think are the opposite side of the same coin, really. So we've got one question in, which is how do we persuade our partners to let go and trust communities? And the second question, which I think is almost the flip side of that, is how did you reach out and recruit people and communities for input? So it's that how did you engage people to trust and let go? And how did you encourage communities to step into that space?
Yeah, can I start with the second one first, if that's okay, Lenny? So we recruited people on the basis, this sounds awful to say it, but on their complaints. So people who had very vocal complaints, we used to call them the awkward squad, because they had experience of services which were not good. So why not turn that negative experience into something positive? You know, let's turn that hostility, anger into, let's help change this service. You've experienced a terrible service. We're just doing the same thing actually in Bolton with. I can never say this right. I'm still new to the NHS. There'll be people on here who can say it better than me. Nosocomial infection, nosocomial infection. So basically, people who've acquired COVID whilst they're in hospital, who went into hospital without COVID, who managed to acquire it and sadly died as a result during the pandemic. So we had to write to every relative who's lost a loved one to explain what had happened to them, and then invite them to help us to shift, you know, to look at how do we make hospitals safer places and reduce infection. So it's that kind of thing where somebody's had a terrible thing happen to them, but let's try to turn it into something positive by learning from, you know, we have this thing, learning from deaths, where what did we do wrong? What could we have done differently as a system? So I think that's the first point, really, get those people with that real lived experience, whether it's them or their family members, to come and talk to us. I think everyone will have the patient story at their board, and I think those patient stories I've just put a ban on positive patient stories because I was sick of hearing people, everything was wonderful when I came to Bolton Hospital. Well, it's not like that, really. In reality, is it? It's not like that. There are always things that we don't get right. So let's just hear the bad stuff. You know, difficult to hear, but let's just hear the bad stuff and learn from it. But I think it does mean leaders have a different mindset. They can't gloss over and pretend everything's wonderful, as some organisations do, and we know where that ends up. So it requires a more humble type of leadership to be able to sit and listen to bad stuff and to be able to say sorry and we'll learn from it. I think the thing about so that's how I would get communities involved on the basis of their passion for it. I've forgotten the other question, Lenny. Sorry about that.
The other question was about getting staff. How do you convince partners to let go?
Oh, yeah, brilliant. Yeah. I mean, we had some real resistance to the deal, particularly the Community Investment Fund, the 13 million, both politically and from quite senior people on my management team who thought it was too high risk. But what we pointed out was, look at how much we're spending on, because we basically didn't do, this sounds quite controversial, we didn't do any monitoring of 13 million. We just said, look, we trust you. Just do it. Just go away and do it. All these outcomes you've said on this form that you want to deliver, just do it. And of the 500 new projects, and people said, I remember the council meeting where they said people will run off with the money. 2 did out of 500. But 498 went over and above and beyond what they'd said they would do. And that trust, that shift in the relationship, as I said before, you know, people who were very cynical and sceptical about the council giving them money initially said, and have been involved in urban programmes, single regeneration budget, city challenge, all of that funny money, just said, this is the shift that we need, where, you know, we believe in you. You're part of the community. Let's do this together. It's not a paternalistic, we'll give you a grant and we'll monitor you. We'll spend more on monitoring you than you actually get. And that's what's happening very often. So turning it on its head and then saying to people, don't interfere. Just let people get on with it. They're doing a better job than you. And just the proof of that, that's 7 healthy years. I can't prove, hand on heart, that 7 years of extra healthy life expectancy was down to the Community Investment Fund. But there's got to be a correlation there. There really has. And the King's Fund said we should have done more monitoring. But to be honest, I think you can spend so much time on monitoring and business cases, and we know instinctively what we need to do. We've just got to have the courage to do it.
So I think it just leaves me to say thank you very much for joining us today, Donna. And it's been a real pleasure.